you. I guess I'm going first. Brian asked me to put together a presentation, some aspect of the healthcare reform, and he asked me to prepare remarks that are both informative and interesting. They'll last about 15 minutes, and that's a real challenge for me to be either informative or interesting. Now, I'm going to be speaking about the individual mandate, which is part of the Affordable Care Act. Maybe you've heard about it, maybe you haven't. When I first started putting together my presentation, I thought I could do a brief overview of the individual mandate and what the Republicans are doing to it. But it's really difficult to do that. So I've put together an outline that hopefully you can follow me, and I'll just emphasize certain points. Okay, the Patient Protection and Affordable Care Act was passed in 2010, and major impetus was the fact that we had 47 million people that did not have health insurance at that time, and that's 47 million that didn't have health insurance all year long. There are about 100 million that didn't have health insurance part of the year, so the problem is very bad. Now, there are other aspects to the Affordable Care Act. The legislation's 1,000 pages long. It's an incredible piece of legislation, and they attempted to deal with the issue of quality of health care and effectiveness of treatments. But most people are familiar with the Affordable Care Act in terms of its attempts to cover people that didn't have health care insurance. Now, the Affordable Care Act instituted certain insurance reforms. There's no lifetime caps on health care coverage, as there were in the past. Some insurance policies would say you have $1 million lifetime, and we're not going to cover you after that, or even lower limits. Okay. A major one is that there's no discrimination on the basis of pre-existing conditions anymore. This is more in line with what other countries do. Health insurance policies used to cherry-pick clients. They would only insure people that did not have pre-existing conditions. They would only insure, in effect, people that didn't need insurance. They'd only insure healthy people. Now they can't discriminate on the basis of pre-existing condition. Okay. Now, there are two mandates regarding the purchase of health insurance. One is for large businesses. A lot of people think that the Affordable Care Act required all businesses to provide insurance, but that's not true. It only required businesses that had 50 or more full-time employees to provide insurance. Smaller businesses, which is most companies actually, don't have to provide coverage, although there are subsidies from the federal government to help, well, there were until recently, to help them provide coverage. What we're really going to talk about today, though, is the next one. Individuals must purchase insurance if they don't receive it from another source. That's the individual mandate. There are federal subsidies available, and they're for people that can't afford insurance. The Affordable Care Act established state exchanges for the purchase of insurance. In California, it's called Covered California, and the idea is that you could go to the website and there would be different insurance companies competing for your business. It hasn't really worked out that way, but it's a good start. Now, excuse me, the enforcement of the individual mandate. What happens if you don't have proof of insurance? Let's say that you're an independent contractor, you're healthy, you don't work for a small business, or maybe you work for a small business, but you don't feel like paying for insurance. You want to just take your chances. Well, when you file your income tax return, if you can't say under oath that you have insurance, then starting in 2014, there was a $95 penalty. $95, not much of a deterrent. Theoretically, the penalty would increase each year to the point that it was at least equal to healthcare premiums, so people would say, well, what the hell, I'll just buy the insurance. Didn't actually work out that way. Trump administration does not enforce these penalties anymore. And last year that they were enforced for tax returns in 2015, the average penalty was only $330. So it's still a weak mandate. It's still cheaper if you're healthier, especially if they can't discriminate on the basis of pre-existing condition, to wait till you actually need the health care insurance. And that's really what the next paragraph is all about. Insurance reform and the individual mandates are related, okay? If they can't discriminate on the basis of pre-existing condition, you have to have a mandate, because otherwise, people that are healthy will not purchase insurance until they need it. The only people that will buy the insurance are people that are in need of health care. Healthy people won't buy it because you can wait until you actually have an injury or disease and then purchase the insurance. So once you do not have discrimination, you prohibit discrimination on the basis of pre-existing condition, you have to have some kind of mechanism to force healthy people to purchase insurance because they pay for they offset the cost of treating people with disease. Does this make some sense? That's what the large business mandate was intended to do, and the individual mandate as well. Okay. Now, in 2012, there was a major case involving the Patient Protection and Affordable Care Act, National Federation of Independent Businesses versus Sibelius. And there were really two issues the Supreme Court decided. One was the mandatory expansion of Medicaid, which we're not going to talk about today, but we can spend a week on. And the other was the individual mandate. The issue was, and I followed this case up through the lower courts when I got to the Supreme Court. And so I got to the Supreme Court, and I read this with interest. The issue really was this. How could the federal government require private individuals to purchase products from other private individuals? What jurisdiction does the federal government have to do that? I mean, how can the federal government tell you to buy something for me? How does that make any sense? Well, that was challenged, vigorously challenged in the Supreme Court. And the government argued, well, the government argued everything. They threw about 10 arguments sort of up against the wall to see what stuck. And their primary arguments were rejected. But about in the sixth argument down the list, Chief Justice Roberts said, you know what, this may make sense as a tax. Okay? In other words, that federal government can't levy taxes, right? I mean, we all know that. So consider this $95 in 2014 and increasing each year after that as a tax. Either you show that you purchase insurance or you pay a tax alternatively. So it's considered to be constitutional as a tax, and even though I've been using the word not as a penalty, that's very important here because penalty sounds like penal. It sounds like a criminal sanction. If it were a strong mandate, if you had to pay a lot of money when you don't buy insurance, that sounds like a sanction. And if it's a sanction, then that implicates due process. You may have a right to a hearing and all the rest of it. They didn't want any of that. But if it's a weak mandate, then it's not a penalty. It's constitutional as a tax, but not a penalty. We'll come back to this later, okay? Now, the individual mandate has been somewhat successful. There are 47 million people without insurance, and about 24 million people have insurance that didn't before, for a lot of reasons, but the individual mandate probably accounts for some of that. But there's still a lot of healthy people that are willing to pay the tax instead of buying insurance. Then we have, let's fast forward to the American Health Care Act, okay? Trump Care, okay? The Health Care Act, which they're debating in the House right as we speak, eliminates the business and individual mandates, and it eliminates most subsidies for individuals that can't afford insurance. Now, instead of subsidies, it provides tax credits for people that can't afford insurance. You pay less tax if you can prove that you have insurance. So it's not a subsidy from the government, but you pay less tax if you show you have insurance. Okay? And it retains the insurance reforms that we talked about before. No lifetime caps on coverage and no discrimination on the basis of pre-existing condition. Oh, and there is one aspect of healthcare reform I forgot to put in here. That is, people can stay on their parents' health insurance until they're 26, so that's big with you guys, right? Right? It was only until they're 18 before the Affordable Care Act. Okay. Now, I had indicated to you that it seems to me and a lot of other people that if you don't discriminate on the basis of pre-existing conditions, you have to have some kind of mandate. Right? Well, they get rid of the mandates. They say, we don't like big government telling you what to do. So what kind of mechanism do they have? Well, right now, their mechanism is this. Insurance carriers may impose a 30% surcharge for 1 year on applicants for failing to have prior coverage. So let's say that the price of an individual health care policy is, say, $10,000, and you don't have health care the prior year. You just took a risk. Well, the insurance carrier you sign up with can charge you 30% more. Okay? But is that any stronger of a incentive than the tax under the Affordable Care Act? I think it's actually weaker because they can only charge 30% more for the first year of coverage. So isn't there kind of a perverse incentive to stay uninsured as long as you can? Because if you stay uninsured for 1 year, don't buy insurance, then instead of $9,000, you have to pay, 11 something. Okay? But if you stay uninsured for 2 or 3 years, you still only pay 30% more that year you finally sign up. So it actually makes much more sense not to enroll if you're healthy. So it's actually weaker than the Affordable Care Act. Okay? So this is where we get to my opinions, okay? And this is where led me to realize Bernie was right all the time. For the reasons I've just indicated, I think that the tax under the Affordable Care Act and this surcharge are too weak to really prevent healthy people from signing up. So let's just consider quickly what other countries do that have achieved universal health care. There are two basic approaches. Now, one is to fund health care through general taxation. And the prime example of this is the National Health Service in the UK. They spend about half of what we do on health care. They have better mortality rates than we do. Nobody goes bankrupt. Nobody pays a medical bill most of their lives. You can get health care insurance in the UK, but private health care insurance is very expensive. It's socialized medicine. There's a single payer, and most of the hospitals are public entities. Everybody pays into the system through general taxes. Nobody can opt out. So even if you get private insurance, you're still supporting the NHS. It's my favorite healthcare system in the world, frankly. I'm just kind of an Anglophile in general. Brian asked me once in a while, I said, why would you leave the benevolent protection of the crown in the first place? And I said, I don't know. Why the hell did we do that? That's a single payer, socialized medicine. I think it's politically unfeasible. All right, so let's look at a couple of countries that use private health care insurance to cover most people. And the two that come to my mind that are most similar to the United States are Switzerland and Germany. Now, Switzerland has an individual mandate. If individuals do not purchase insurance, then they are automatically signed up for a policy, and that policy can go after the person for premiums that aren't paid. So they're actually in a contractual, the government makes sure that they're in a contractual relationship, and the company can institute debt collection proceedings for premiums that aren't paid. Pretty draconian. Okay? Probably wouldn't work in the US. Germany's system is kind of interesting because it's in a way similar to the National Health Service. There's employees and employers that pay the 15% payroll tax. So it comes out of taxation like Medicare tax for us, and the employer and the employee split the difference. So it's mandatory, it comes out of the employee's check, and then when the employee can choose between different policies called sickness funds. Unemployed people still have to pay on a sliding scale. So in those two countries that are more similar to us in the sense that they use private insurance, they have a much more robust mandate than we do here. I think it'd be politically unfeasible. In fact, I think it would be unconstitutional, and I'll tell you why. And this is why I end up concluding Bernie was right. because that's Sebelius case. Now, I hope this isn't too technical. The major argument that the government used in the Supreme Court as to why the individual mandate was constitutional was that it was a legitimate exercise, the mandate was a legitimate exercise of Congress's power to regulate commerce between the states. Congress can do that. And they said, we're just regulating commerce by requiring people to buy insurance. And the Supreme Court said that argument won't work because you're not regulating commerce, you're attempting to create commerce. Because there is no commerce, and that's what you're trying to do, is create commerce so you can regulate it. And they said that doesn't make any sense. So you cannot force people to, so the court continued, you can't force people to buy a product, but you can tax them if they don't. And that's what the individual mandate taxes, okay? Well, because of that rule that you can't force people into a business relationship, you can tax them if they don't, but you can't force them into it. That's why we could never have a system like Germany or Switzerland, because that's exactly what they do. So why do I think Bernie was right? Because Bernie said, let's do it through taxation. We all pay into the Medicare system right now, whether you use it or not. He wants Medicare for all. A single payer, just like the UK. We just pay taxes into the single system, but it wouldn't be socialized medicine because it's just Medicare payment program. We have 5,000 hospitals in this country. Most of them are private. They could still be that way. We have a single payer funded through taxes, so nobody gets out of it. Maybe Trump does. He doesn't pay much. But it'd be so simple. It'd just expand Medicare to cover the people that don't have insurance. Relatively speaking, Medicare is a very efficient program. Single payer, low administrative costs. That's really what Taiwan does. They have a single payer, and we spend almost 18% of our gross domestic product on health care. All these other countries I've mentioned spend about half that. They have better mortality rates than we do, and they cover everybody. Taiwan spends about 7% of its gross domestic product on health care, and they cover everybody. So I hope some of this made sense. That's why I put this in an outline. So most of this is accurate, so you can take this with you if I went too quick. That's why I think Bernie's right. It was a surprise to me. Anyway.
Hi, good afternoon. I would like to talk to you today about the future of traditional Medicaid. Much of the current focus on Medicaid in the current legislation that Gary talked about, the American Health Care Act, which is before the House of Representatives, has focused on what to do about the expansion population, which was part of the ACA. Those were previously uninsured, predominantly childless adults with an income of less than 138% federal poverty limit, who are now covered in 31 states and DC under Medicaid because those states expanded Medicaid. But today I want to talk about the other Medicaid population, those that are covered under what I refer to as traditional Medicaid, or the population that was routinely covered under Medicaid both pre and post ACA. So first I want to give you just a quick little primer on Medicaid. Medicaid is a joint federal and state program that, together with the Children's Health Insurance Program, better known as CHIP, provides health coverage to about 77 million Americans, including children, pregnant women, parents, seniors, and individuals with disabilities. About 11 million of these enrollees are part of the expansion population, while the remaining 65 plus million are covered under traditional Medicaid eligibility standards. Medicaid is the largest provider of health insurance for children and adults in the U.S. and provides a critical financial support for the nation's safety net clinics, hospitals, long-term care facilities for serving the poor and uninsured. In order to participate in Medicaid, federal law requires states to cover certain groups of individuals. Mandatory groups include low-income families, qualified pregnant women and children, individuals receiving supplemental security income, and poor elderly who meet eligibility thresholds. Currently, states have significant flexibility to design their state Medicaid programs to meet the specific needs and priorities of their residents, and they can seek additional flexibility through what is known as a Section 1115 waiver authority. Thus, while the federal government sets minimum standards, states can expand eligibility, offer optional benefits, require premiums and cost sharing, and determine how to provide care and pay providers. Federal funding for state Medicaid programs is determined by what we call the Federal Medical Assistance Percentage Formula. So the short is the FMAP. The FMAP formula is based on state per capita income. States with lower per capita income have higher FMAPs and therefore receive a larger portion of federal funds. State FMAPs currently range from about 50 to 74%. So for example, Mississippi has the highest, is funded at the highest FMAP at 74%, which translates into Mississippi receiving 74 cents of federal money for every Medicaid dollar spent by the state. In comparison, California is one of 13 states with an FMAP of 50%, meaning that California equally shares the cost of Medicaid with the federal government. As an entitlement program, anyone who meets eligibility requirements has a legal right to enroll in Medicaid, and then the states are then guaranteed that the federal financial support for their Medicaid programs based on this predetermined FMAP. Total Medicaid spending was $552 billion in the fiscal year 2015. On average, states spend about 17 cents of every general revenue dollar on Medicaid, which makes it the second largest state expenditure after K through 12 education. Nationally, Medicaid covers nearly 1 out of every 4 children under the age of 6 that live in poverty. In fact, children represent almost half of Medicaid enrollees, but account for less than 20% of Medicaid spending. Medicaid accounts for approximately $1 of every $6 spent on health care in this country, and importantly, 2/3 of Medicaid spending is for care of the elderly or persons with disabilities. In fact, Medicaid is the nation's predominant source for financing long-term care, and it serves 1 in 5 Medicare beneficiaries and 2 in 5 people with disabilities. With regard to California, 13.3 million Californians are covered by the state's Medicaid program, which is known as Medi-Cal, which is more than 30% of our state's population. Medi-Cal covers 3.16 million low-income children in California, which is about 46.7% of California's Medicaid population, so it mirrors the national average, about 50% of Medicaid population being kids. And 50% of all births in California are financed by Medicaid. The present legislation moving through the House of Representatives, the American Health Care Act, which has already passed through the House Energy and Commerce, Ways and Means, and Budgets Committees, and which will be considered tomorrow in the Rules Committee, and then will go to the floor for a House vote on Thursday, which, by the way, is the 7-year anniversary of the signing of the ACA, proposes to repeal and replace the Affordable Care Act. As a result, the media is focused most on what will happen to the Medicaid expansion population. However, the Medicaid cuts in the AHCA go much further than a mere reversal of ACA policies. They will fundamentally change the structure of Medicaid and shift costs and risks to states, beneficiaries, and healthcare providers. It's important to recognize that throughout the 50-year history of Medicaid, costs and risks have been shared by the states and the federal government. The guarantee of federal Medicaid matching funds with no preset limits has given states the capacity to provide health care coverage to specifically defined populations, and it allows states to manage increases in health care costs that are fueled by things like inflation, the emergence of new expensive treatments, drugs, or new public health threats, and the aging of a population. Because states share the cost of Medicaid, they have a strong incentive to run efficient and effective programs. In fact, average state administrative costs are about 5%. The growth of spending in public insurance programs is slower than the private sector. The House bill proposes to change the federal role of financing Medicaid by capping federal contribution to Medicaid, resulting in federal savings through substantial cuts at the federal level, but this effectively shifts the costs and risks to the states. While the current legislation calls for per capita caps to go into effect in 2020, I'm going to address both block grants and per capita caps because given, as of last night, block grants are now being added to the legislation. We don't have specific language yet, but we know that block grants are going to become available. So under block grants, states would receive an annual lump sum to spend according to broad federal guidelines. Again, we don't know what those guidelines will be at this point. The Medicaid program costs in excess of that federal grant in any one year then become the responsibility of the state. Under per capita caps, federal spending is capped per enrollee, which is determined by a base year amount. In this case, it will be based on 2016, that is adjusted over time by a measure of general inflation, which is the Consumer Price Index, which is actually less than the growth of healthcare costs. States will receive this amount per enrollee multiplied by the number of enrollees in the states for a specific period of time. Under current proposals, the per capita caps would be calculated for certain subpopulations, and those are divided into the elderly, the blind and disabled adults, children, other adults who are generally low-income parents, and then the expansion population. The Congressional Budget Office estimated that while Medicaid costs would grow at 4.4%, federal matching funds would grow at a rate of 3.7%. Given the legislative text in the budget processes, states will not know the final cap for each fiscal year or whether they exceeded that cap until the first quarter of the next fiscal year. If a state exceeds its cap, the federal government will claw back the excess amount during that next fiscal year over the 4 quarters. Under this scenario, states are left with limited options to address likely funding deficits, as most states already operate programs with low administrative costs, and provider reimbursement rates are well below other payers. Here in California, we're the 4th lowest. And major investment services such as Fitch and Moody have recently warned that the cost and risk to the states, which have to balance an annual budget, will negatively impact state credit ratings. Overall, according to the CBO, the AHCA will result in a reduction in Medicaid spending of $880 billion, which is a 25% reduction in Medicaid spending and a 17% decrease in enrollment over the next decade. Importantly, the impact of per capita caps was not scored by the CBO. Rather, it's rolled up into the estimate of all Medicaid savings, so we really don't know the relationship between these two different populations. So what does this mean practically for the populations currently covered by Medicaid? First and foremost, the proposed fixed block grants or per capita caps will significantly alter states' ability to respond to changing coverage needs related to economic recessions, public health emergencies like the recent Zika outbreak, the Flint lead crisis, or the opioid epidemic, and other disasters, the growing aging population, and the emergence of new but costly treatments. More specifically, my area of interest and expertise is the pediatric population, and because they represent some of the most vulnerable but least often talked about among us, I'm going to spend a few more minutes telling you about how these particular block grants and per capita caps could impact kids. Under block grants, it's entirely unclear what amount of money would be allocated to children's health care costs and how those allotments might change over time. In fact, we have no language at all guiding us in this regard. However, under the proposed per capita caps, reimbursement for each child enrolled in Medicaid will be presumably based on the health care costs for an average child enrollee, which already, as I've noted, is low compared to the costs of other populations. As a result, the pediatric subpopulation may receive inadequate funding, particularly for the care of children with special health care needs whose costs are significantly higher. So there's going to be an imbalance in the amount of money available to care for kids. Moreover, and this is an area that a lot of people haven't thought about, school districts bill Medicaid for certain medically necessary services provided to these children with special health care needs under the Individuals with Disabilities Education Act. And they play an important role in meeting the health care needs of low-income children through their school-based health centers. They could experience a 30% reduction in Medicaid reimbursement, which results to, the estimate is about a $4 billion shortfall to school districts across the country. This means, the school psychologist, there won't be any money to pay for the school psychologist in a school district. And it's important to recognize that in rural areas, school districts are some of your largest employers, so there could be significant impacts in terms of employment. This would also negatively impact specialized instructional supports that children with special health care needs require to be educated with their peers, and it would interrupt the physical, mental, and developmental health services currently provided to other low-income students. As states grapple with balancing annual budgets, services such as the early periodic screening, diagnostic, and treatment services, which are a special pediatric benefit under Medicaid, could also be restricted or even eliminated. Medicaid financing reform will also impact the child health care delivery system. While children's hospitals constitute less than 5% of U.S. hospitals, they account for 35% of all hospital days for children on Medicaid and 53% of all hospital days for children with complex medical conditions. Currently, Medicaid reimburses children's hospitals at about 80% of the cost of care provided. Block grants or caps have the potential to decrease these payments further, which can undermine the fiscal stability of this really important specialty healthcare system. But that's not all. As noted, Medicaid is a major government program. It accounts for about 17% of the nation's healthcare expenditures. It's the primary payer for long-term support services for individuals with disabilities, and almost 2/3 of people in nursing homes pay for their care through Medicaid. In response to fiscal pressure, states might reduce already low provider payment rates, forcing out many current providers. And when we talk about providers, we mean much more than clinicians. We're talking about hospitals, nursing homes, home health agencies, and so forth. This would limit access to care for all populations, and it would be particularly detrimental for people who need specialized treatment and long-term care services. In conclusion, present efforts to reform Medicaid financing will result in a radical restructuring of the long-standing safety net program, which now provides essential health care services to about 77 million Americans, 33 million of whom are children. Block grants and per capita caps have the potential to force bad policy choices and cause substantial conflict as groups with diverse needs compete for limited resources. The text of the AHCA has only been available to the public since March 7th, after which it quickly moved through 3 House committees. By contrast, when considering the Affordable Care Act in 2009 and 2010, the House held 79 hearings over the course of a year, heard from 181 witnesses, and accepted 121 amendments. The Senate adopted the Affordable Care Act only after approximately 100 hearings, roundtables, walkthroughs, and other meetings, and after 25 consecutive days in continuous session debating the bill. The current House leadership hopes to get the repeal and replacement legislation through the House in what would be 3 weeks. We need to have an open and vigorous evidence-based debate regarding the benefits and consequences of this reform. We're talking about upending a system that's been in place for 50 years. That our most vulnerable population relies upon. Thank you.
Okay, so I am a professor of communication, and usually what I'm interested in is watching how people talk about health issues in the settings where they actually take place. So I'm usually in the doctor's office, for example, while you and your doctor are communicating with each other. But I'm interested in words, I'm interested in language, I'm interested in how those conversations unfold and the implications of how we talk about health, not just in those kind of more intimate interpersonal interactions, but also all the way to kind of the social political discourse that we're engaged in. So what I'm going to talk about today is I'm going to not go all the way and do a full-blown analysis, but do kind of a brief abbreviated version, and look at some of the language that's being used to talk about what I think Gary appropriately referred to as insurance reform as opposed to healthcare reform, because I don't think this law, the law that's being currently debated in the House, does anything to reform actual health care and the delivery of health care. So let me tell you a little bit about this dude named Kenneth Burke. He was a rhetorician. And he was really interested in words and language, and he liked to make up a lot of his own words, which makes him kind of complicated and difficult to work with, even for some of my very smarty pants rhetorician colleagues. But one of the things that he asked us to consider when we're looking at the ways in which people are engaging in public rhetoric, public discourse, giving a presentation or a speech, is to look at the language that they use to understand their motivations. Okay, I'm not going to do a full-blown Burkean analysis, but I will use some of his terms and some of his concepts to help inform our thinking, and specifically looking at a clip. So the first thing that he said was that we should think about, and he loved religious texts. He was really into theology, and so he borrows a lot from theology in some of his language. So he talked about God terms and devil terms, and God terms are always positive. And all the terms that are used that might be God terms, there's like usually a primary term, and then you'll have other terms that are positive that also support that term. And I'll give you an example. One during this conversation might be freedom. And then you're going to have a series of other terms that are used that we've probably heard over the course of the last couple of weeks, like choice, affordable, access, control, and maybe even promise, as a kind of, some people might call trigger words that make us think about this concept of freedom, that serve that term of freedom. On the flip side, you'll have the devil terms, which are always negative, right? And so you'll hear in this kind of conversation we're having right now about healthcare, you'll hear collapse, you'll hear disaster, you'll hear things like implode, or my personal favorite, because I study dying and death, the death spiral, right? Okay, so what I thought we could do is take a look at a clip, and it's just 2 minutes long, and then I will come back and talk a little bit about it and describe what Burke would ask us to pay attention to. John, okay? All right.
Afternoon. This is the American Health Care Act. It's been a long time in coming. This bill, the American Health Care Act, it keeps our promise to repeal and replace Obamacare. It delivers relief to Americans fed up with skyrocketing premiums and fewer choices. It moves us away from the broken status quo toward a better, patient-centered system. That means lower costs for hardworking families. It means more choices and competition so that you can buy the plan that you need and that you can afford. It means greater control of your health care. As you know, this is the culmination of years long of an inclusive process that we've been doing here for years. Last June, as part of our Better Way agenda, we put forward our vision for health care. After the election, we began to work with our counterparts in the Senate and with the Trump administration on this plan. I want to thank President Trump. I want to thank Vice President Prince, and I want to thank Secretary Price for their support and their hard work in getting us to this repeal and replace point. I also want to thank Chairman Brady, who's going to be joining us in a minute, and Chairman Walden for their leadership. Now this bill will go through the regular order process in the House. As it does, I encourage all Americans to read this bill online at readthebill.gop. Go online and read the bill at readthebill.gop. Doing big things is never easy, but we have made a promise, and we're going to keep that promise. We made a promise to repeal and replace Obamacare with conservative solutions and reforms. That is exactly what this bill does, and that's why we're here. Thank you.
One of the things that I have found interesting in kind of following the conversation that's been taking place about this new law is that we know that 7 years ago, when the Affordable Care Act was implemented, it quickly got this moniker that was called Obamacare, and that's going to become important, right? That term was used as a way to get opponents of Obama and his presidency to really have a negative attitude towards the bill. Now, over the 7 years since the bill's been implemented, people have come to really actually like Obamacare. And I think the Republican Party discovered that the use of that kind of language to use it as a derogatory term was no longer effective. But we still can hear the ways in which the kind of language about repeal and replace, and repeal and replace specifically Obamacare, keeps getting repeated. And that's another important technique, I think, that is used. So what did Burke say that we should be doing, that a rhetor, like a speaker, should be doing in order to manage the terms, the language that's being used? What is the motivation? What is the drive for speaking? And he liked to use this term guilt. And he meant guilt not in the typical way, because again, Burke liked to play with language. He didn't mean like I feel guilty about something, but he said guilt could be any kind of anxiety that we have, any kind of stress that we have. It could be bad feelings about something, right? So broad kind of concept or definition of what guilt means. So we might argue that in some cases, I mean, there are many, I could have picked many different clips of Paul Ryan talking about like being at Kager's and dreaming of getting rid of, insurance and kicking people, Medicaid, getting, reforming, the healthcare law. I could have picked even clips where he tries to argue that, that those of us that are healthy shouldn't pay for people that are ill. That's not how insurance works. It's actually literally how insurance works. I could have picked many, but so what is he trying to do? What is he trying to do in this concept of offloading guilt? What is a strategy? Well, one strategy that is used is to find blame, to scapegoat, essentially, right? To find some way, some place to move that guilt. Right? So how do we know that if our highest goal is to have freedom and to have freedom of choice in our healthcare context, which is what he argues, right? He says, well, this bill is going to do it for you, right? It's going to give you more options. It's going to lower costs. It's going to give you access, right? All of these things, by the way, I don't think a single commentator has agreed with, right? There's just no evidence that this law will actually accomplish that. But I think what he has argued and what the Republican Party has historically argued and done very effectively is to repeat choice, affordable, access, control. Even in that 2-minute clip, we hear the word control twice, right? We hear the word choice twice. We hear the word promise at least 4 times, and repeal and replace I didn't even count. Right? So all of those things, that use of the language then serves that higher goal, which is to accomplish freedom for all of us, right? Freedom to make these great choices. Okay. Well, I think what's sad and unfortunate, and even in his 4-point plan, did anybody see the TED talk that he did, where he had the PowerPoint slide? And yes, I watched it. 30 minutes of my life that is gone. But he says, 4 things that will happen. We're going to lower costs. We're going to give you more choices. We're going to put patients in control. We're going to give universal access to care, which he claims are all conservative ideals, right? They're all conservative ideals, right? Serves the purpose of conservatives. We're going to follow through on our promises, right? This is a nice strategy to try to push off and manage and deal with the guilt. Okay, so one of the things that I think is also interesting about this is that there's just simply no evidence for it, right? There's simply no evidence that will lower costs, that patients will have more control. And I think I don't know if it's an interesting strategy, but I think that it plays on the idea that we didn't have choice before. Right, that we didn't have choice before. So let's just think about the history of the law. Before Affordable Care Act, we may or may not have had private insurance, but we didn't have more choices necessarily, right? Because we always, if you have limited income, if you have a health, even here at USD where I have employer-provided healthcare, I have limits on who I can go see, right? So the constant repetition of this idea that somehow we're going to create a system that has more choice is simply false, right? But when we hear that kind of language, we think, yes, that's what I want. That is the American way, right? Choice is what this is all about, right? But we actually have limits. And I think that there's not any real recognition of the ways in which those limits are real and actual, and that we all function under those limits day in and day out, right? So if you're going to try to find a scapegoat and a common enemy, I think part of the urgency on the part of the Republican Party right now to push this bill through, as Eileen pointed out, that we're doing this in like a matter of 3 weeks, is that part of my argument is that the major scapegoat in the past used to be Barack Obama and used to be Obamacare. The longer he is out of office, the more that people are starting to realize that their benefits are at risk. I think that the value of that particular scapegoat goes down. That currency goes down every single day. So if they can get a bill passed, and they can get it passed even within the next, I mean, there's, whether the House and the Senate will both pass the bill, I think is questionable. But they don't have a common enemy anymore, right? And in Burke's world, the ability of a speaker to identify a common enemy that you and I have as the audience, the more effective the message is, right? So Burke would say that in the past, he would probably say he's dead, but he would probably say that the Republican Party had been very effective, right? Because they had a common enemy that they could offload the guilt, the anxiety about. They could upload it onto Barack Obama and his law. But I think as more time goes on, that the effectiveness of the freedom message, the control message, the choice message, and the enemy that is Obamacare goes down, right? So the flip side of this is that I don't see, unfortunately, the Democratic Party taking advantage. I don't see them coming in with their own language that would speak to issues of freedom or control or choice, if those are the highest values. I don't see them very strongly anyway talking about the moral imperative, the ethical imperative of maintaining the systems that are in place, right? I don't hear that kind of language taking place very often. But I think, I don't know, I'm trying to frame this in some ways in the most positive way possible, that there might be hope for people who may be very much supportive of Affordable Care Act, that it will be successful in the eyes of the public, that it will stay and continue to be successful. But right now, I think the strategy that the Republican Party is using will only last so long, right? They'll only have so much that they can draw upon. Yeah. So I think I'll just leave it at that. That way we can open for questions, comments. Yeah, go ahead.
Well, I just want to thank the three of you so much for your eloquent sharing of your expertise, first of all. And if I may, I would like to take this opportunity to share with the audience and the three of you with some of my own experience about the healthcare. Well, I'm over 50 years old. And if I can stand here so I can, because I grew up from Beijing, China, the Communist Party regime. So I've been through the, what they call the kind of a universal healthcare system. And also, when I came to the United States at age 29, so that's 29 years ago. So so I've been through the two kind of a healthcare system. So in my experience, I would say I prefer like a privatized kind of a healthcare system. Here's the reason why. My brother and sisters, they worked, like especially my oldest brother. I have like 5 siblings. I'm in the middle. So the healthcare system basically in China is free. Everyone, the healthcare is paid by the employers. So my eldest brother, he's worked in the factory, okay, that produce like a soap and detergent. So his factory got basically because the closed down because of the healthcare cost. They bankrupt his factory, and so he lost his job. So basically, the workers they go to they abuse the healthcare system. So they constantly use they go there. My brother kind of they carry the big gigantic soap bar and go that's constantly causing back pain. So he would go to the doc, can I have 3 days off? So they give him 3 days off. And the other one gets 3 days off, get all kind of painkillers and whatever. So a lot of the worker, all of a sudden, 5 people out of job. So the assembly line, they don't have people. So then the production, there's only one factory producing that product. So then they don't have, whatever. So there's the consequences. So the end of this, the long story, the short is that the factory, because of the constant this kind of occurrence, so causing the factory closed. Okay, that's that. So the bigger picture at the macro level is the country, the doctors, the Chinese doctors, they don't care, because there's so many, if you look at the room, the patient and they're waiting, and then there's so many patients, the doctor said, okay, what do you have? Oh, I have, this and that, they will come say, okay, what do you want? They all have they're so impatient, and they were just, there's so many patients, there's the doctor that's, they just become don't care anymore. There's too many, everybody, anything, if everybody has something, it's nothing special anymore. You know what I mean? So then, here in the United States, for me, my dissertation, I study hypertension. So recently I discovered that health policy-wise, already with the hypertension, they already changed the policy, although you have the access, everyone get reimbursement. But hypertension, already they define hypertension for many, many years, for the past 20 years. Hypertension has always been defined as blood pressure in 2 different occasions. They measure your blood pressure is 140/90. That you have a diagnosis of hypertension. So you would be eligible for treatment and care. But now, they already changed the definition that if you're 60, your hypertension is going to be defined as 150/90. Why? Because for the money saving, you know how many people would not be eligible for treatment and care? You know the risk you run into. It will be a stroke, heart attack, kidney, chronic kidney failure, or heart attack, and then, all of the heart failure, a lot of consequences because of that. But there are subtle, the people that upper echelon, they can change people, the stakeholders, they can change the policy to influence the healthcare that you wouldn't know. Okay, so and then the same thing with the pap smear. The pap smear used to be every year. Now the policy already changed. You won't be normal people, whatever, age 35 is every 3 years, or they're trying to change it to every 5 years. A certain population you change. They made the algorithm is so complicated because it's all for cost saving. So on that end, you may not know, because we're in the medical field, say for me, a nurse practitioner, I review this policy, I say, oh, what's the purpose? It's for the cost saving. But lay people would not necessarily know that, right or not? So I just want to give you a sense of, simply because you have a card, you have insurance, it does not mean that you have access.
Mm-hmm.
So just think about that. Thank you very much for your attention.
Thank you.
I was hoping to maybe say some things about what Jillian was saying about language and the role that language is playing in kind of framing these conversations. And so I was going to offer perhaps 2 things that philosophers of language talk about that might be relevant, and I was hoping that maybe you could comment on whether these types of ideas map on to what you were talking about in terms of offloading guilt or something like that. So I think there are 2 things going on in the clip that we saw. So and one of the things is what Jillian brought up, which is something like Paul Ryan is able to get words into the lexicon with which we use to have the discourse about healthcare. That's a kind of power, it's a kind of linguistic power that I say don't have. So thinking about, you know, why he has that power and why I don't is perhaps important. And then also thinking about rules that kind of govern having a cooperative conversation. So I think this might be relevant to your point on why when we hear over and over again, you're gonna get choice, you're gonna get choice, you're gonna get choice, why do we automatically think that that means we didn't have choice before? This is kind of Gricean notion, right, that, well, it's because if we're having a cooperative conversation, you tell me things that are informative. Why would you be saying that if I didn't have it before, right? So there's these kind of assumptions that we have that he's being cooperative, right? We're having this kind of informative conversation. And then that compounded with this idea that he has a kind of power that I don't, kind of magnify, right, the kind of issues that you're bringing up and make the language kind of a problem. So I'm just wondering if that's kind of mapping onto what you were talking about, if those are different ideas or.
No, I mean, I think they certainly work together, and Eileen and I were talking before about this the kind of issue of that cooperative conversation that you're describing. You know, that there, you know, the implication that there was no control before, that we somehow had less control as a result of Obamacare, and now this is going to give us more control. But I think we were also talking about the idea that at this particular moment, to have a cooperative conversation when you can just simply say whatever you want and not substantiate that becomes even more problematic, right? That we are seeing over and over and over again that Paul Ryan in particular just simply asserts something and that we're supposed to believe him, and that maybe in some cases we don't even go so far as to interrogate whether or not there's truth value in his claim. Because if you're gonna, I mean, I think we've heard Trump and we've heard certainly Ryan claim that they're gonna lower costs, give us better care, and everybody's gonna have access to it. And that just doesn't, I mean, that doesn't even, I don't think that seems realistic to anybody, right? That you could have all of those things in one shot. So how do you have the cooperative conversation that you're describing? How do you have political discourse, is how we might describe it in communication studies, and say, with those kinds of issues coming up. But certainly the power issue, I think, is another thing, right? Who gets to speak and when, and who's invited to that conversation? Because nobody's real, I mean, none of us in this room, I think, are being invited to have conversation about this, the debate that's going on about this bill. It's kind of, I think many of us feel like.
I don't think anybody is.
Yeah,
There's
I
no
mean,
hearings.
Yeah, but I think a lot of people are feeling like it's happening without us. And part of that is, how does that make citizens feel about, you know, where power lies? I think we're feeling like it's very authoritative, you know, which is something he also accused Obama of doing in the past. But anyway.
Well, no, I was just going to say it's very interesting that you brought up the role of citizens, because what have citizens been told? That they're astroturf groups, that they're paid protesters.
Mm-hmm.
There was a representative that told his constituents to shut up, to sit down, you don't know what you're talking about. I mean, these are the kinds of words that are being exchanged in these town hall meetings, and so it really does impact the role of the citizen.
Yeah, and I think we're seeing the public trying to push back on the power, at least in social media. I think you're seeing it, you know, that Gary used the term Trump care, that as soon as the House bill came out, people were debating what to call it. They were calling it "Don't Care" and Ryan this. And,
That's good.
Yeah. And so I think you're seeing, like, suddenly that hashtag became important, at least in some circles, that there was debate and conversation, so that you wanted to call it, like, who was going to own it? Like, somehow that language was going to dictate who owned whatever healthcare law is the outcome. Or does that, I don't know if that's answering.
Well, I mean, I think that's right, and I also think your point about getting kind of the people in power on the other side to kind of start to force kind of press their language is really important, because part of linguistic power is the ability to ignore other people. So Ryan kind of has, you can hashtag all you want, I'm still going to get up here and I'm still going to say, I'm still going to call it whatever I'm going to call it, and you're still going to cover it, right? So that's very helpful.
Yeah. And I think we're seeing it in other things, so like the Meals on Wheels conversation, And that we're also, another interesting thing, I haven't looked a lot at this, but the narratives that are coming up from people who voted for Trump but are also worried about losing their health insurance, that we're seeing that voice enter into the conversation, because that's what the Paul Ryans of the world are really worried about, is getting reelected. So I think there's something, when that we'll continue to hear those voices, is will be interesting. Sorry, yeah. Yeah.
While we're on the subject of language, I was thinking that there's been, at least to me, a complete lack of sort of ethical and moral language in this realm,
Mhm.
as there was in 2009, 2010. Is it fair to say that this might actually be kind of rhetorical smokescreen to not talk about the sort of fundamental premise of public health and how it gets to the very core of sort of the American project? And that's why I think this is a debate, because it predates us by such a huge degree. I guess why, it seems to me like talking about Medicaid expansion and the logistics is obviously vital, right? But it seems to me that in a way that can actually ignore the fact that you're making public health a commercial enterprise, which seems to me philosophically irreconcilable. Is that fair to say? Am I just
I don't know if you want to ask somebody else.
Yeah, no, I definitely think you're touching on an area that we have not come to grips with at all in this country, and that's really this issue is, is health a right or a privilege? I mean, if we really want to boil it down to a dichotomy, that's really what we're talking about. And when we start and I think we really see the discomfort with this conversation when we start talking about the Medicaid population, because suddenly you hear things about, earning, whether somebody earned that that right, or that, that well, if they're able-bodied, then they have to go to work, as if there has to be some kind of earn, this is earned, as opposed to making a decision that there are some people that we should help due to a moral imperative. And unfortunately, I feel like it is that population that does get vilified, that there is a coded stereotype of both, especially the traditional Medicaid population, because I will hazard a guess that I'm not sure that any one of you knew that about 50% of Medicaid enrollees were kids. I mean, was that new news to a lot of you, or that the majority of Medicaid dollars were spent on the poor, elderly, and disabled? I mean, that's not the narrative that is put out there. The narrative is the lazy person who doesn't want to go to work, as opposed to somebody who really is in need. So I agree with you. I don't have an answer, but I agree with you. And I think we're going to continue to butt up against this until we have this conversation about how do we think health matters in our country, especially for our vulnerable populations. And being a pediatric person, I'm going to always default to, kids. I mean, if they don't have a healthy start, what does that mean for our nation in the larger scheme of things?
Yeah, I would just add to that. When I was watching Ryan's, they're calling it his TED Talk on healthcare. One of the things that he gave an example of a small business that had 40 employees, and they have insurance together. And he gave an example. What if 4 people in that business got cancer? And there's a weird conflating of and confusion of pre-existing condition and then just becoming sick, right? Those are two different things. We all have the potential to eventually be sick. So he mixes those terms. But the point of his story was that in this business where 4 people get sick, there are 36 people that are having to pay for these people who got sick, who got cancer. I guess that you're a bad person if you get cancer, and that the rest of us are saddled because the 4 of you got cancer. And that's where you're seeing this budding up of a moral imperative. Do I have an obligation to my fellow sick person to make sure that they're cared for? And does that somehow maybe come back around to me if I ever become sick? Or is it just the corporate interest that is the capitalist interest that is most important that we should be thinking about? And so on one hand, he'll say things like, and so his argument was that that's not fair to the 36 other people, right? This is again where he doesn't seem to understand how insurance works. So his argument is that it's somehow unfair to the 36 that have to pay for their colleagues who got sick. And I think the other thing that you hear is another term, like in my world, when we say patient-centered care, and probably in Eileen's world too, when we talk about patient-centered care, that means putting the patient first, but it doesn't mean that they have all the power and all the control.
Right.
It simply means that it's more relational, right? And that it's as opposed to paternalistic, like I'm the doctor, so I get to dictate the care that you get. But it sets up, again, that kind of idea supports a consumerist conception of healthcare, as opposed to perhaps a different kind of relational, like if you're healthy and I'm healthy, we can all be healthy and better and do better things together, right? Instead, it is this idea that, you know, your sickness might be hurting me, meaning my pocketbook, right? Meaning my wallet. And I think that's really, really problematic. And you hear it, I hear it from even my students, you know, in an undergraduate class, like I hear them, you rely on that kind of language all the time. Should I have to pay for somebody else's? Yeah. So I think you're right on.
Yes, just a question about the elimination of individual mandates now. Since now it's eliminated, so what's going to happen for the insurers, for the companies? So is there any rules that will restrict them from hiking up their prices or stuff like that?
Well, the individual mandates, the insurance companies, it was voluntary participation anyway, and a lot of them were leaving the state exchanges because they couldn't make enough profit. Because the people that are signing up, they had pre-existing conditions, many of them. And the healthy people weren't signing up because there was a weak mandate. So a lot of companies just don't participate anymore. In fact, in 70% of the counties across the country, there's only 1 or 2 plans to choose from. In other countries, there are hundreds of insurance companies that compete. One problem is, and I think the root problem is this, and I should have put this in here. In other countries that use private insurance as a mechanism, it's illegal to make a profit on basic health care. So in Switzerland and Germany and Japan uses private insurance. They can't make a profit on basic health care. So they compete for market share. It doesn't mean they can't make money, but they don't give dividends to shareholders. And so if you take the profit out of the insurance, there'd be less incentive to leave the system, I think. In other countries, they don't have this problem of insurance companies refusing to participate because they can still make money if they're in the market, if they have enough market share. So I probably didn't answer your question at all.
But I also think it's important to point out that even before the ACA, there were many parts of the country where there were only 1 or 2 options to begin with. And a lot of that has to do with just the way healthcare works in the United States in terms of, especially looking at rural areas. You know, when you have limited providers, you know, you're going to have limited options. And it's going to be more expensive. There's less bargaining power. So I think some of those things are obscured in the conversation today. It's blamed on the ACA, but these are conditions that are, they existed pre-ACA, they will exist post-ACA, and certainly there is a question about whether or not there will be, you know, a greater disincentive now for people to purchase insurance, and what does that mean? I mean, there's a lot of insurers that are very skittish. I mean, some have pulled out of the market prior to 2017, and some are talking about it, and there was even some conversations about some pulling them out mid-year. So there's real uncertainty. I think the executive order that President Trump signed back in, probably, I think it was in January, trying to stabilize the market by changing some of the rules around enrollment through and proof of change of status and things like that to kind of shore up the private marketplace, was to try and appease those insurers. But I'm not sure there's definitely going to be continued instability. But I absolutely agree with Gary that the profit issue really skews our system here.
And I think, if I'm remembering correctly from the Congressional Budget Office report, that it's a strong likelihood that premiums
Right.
would go up because
Right.
all of the healthy people don't need insurance now because they removed the individual mandate. And so now if you are in the system, whether you're healthy or not, but you run the risk because you're trying to take care of the people who are sick. So for let's say faculty here, we have employer provided insurance, it could very well go up because we're trying to care for more sick people now. We don't have enough healthy people in the system. So I think there is a possibility that will happen, a very strong one, if the bill passes, right?
I'd be interested in your thoughts on the prospects for there being at some point in the future in the States something like a single payer or universal healthcare system like this. And it's true to say that the English do complain about the national health system. The English complain about everything. It's the industry. But I don't think you still meet anyone from England who would prefer to have the American system, because it just seems to us an absurdity. Although I'm perfectly happy with my healthcare because of how it works here, but I'm not living without health insurance. And so it struck me as first here. It was in the middle, really, of that strange, heated debate about Obamacare and how this was some kind of Nazi plan to kill everybody.
Death panels.
Yeah, so I'm just interested in whether it is a prospect at some point in the future that the United States will look at something like the European system and say, yeah, we're going to go for this, finally. Or is it just so anathema to the American way of life?
Not in any of our lifetimes, I don't think. It'll have to get so much worse before that happens. I mean, Churchill said Americans can always be dependent on doing the right thing after they've tried everything else. And at least, I will say this, and we were talking about this before, at least people are talking a little bit about healthcare now. I mean, people weren't talking about health. Americans, and this is the problem with our education system, seems to me. Americans don't have any idea how our healthcare system works. There should be a mandatory class in high school of the American healthcare system. I mean, Americans have, I'm totally not answering your question, but Americans have opinions on discrete issues in healthcare. Like people have opinions on abortion, people have opinions on physician-assisted suicide. They have no idea how the healthcare system works. And we need to have informed voters. And ironically, I mean, it's what's going on right now, and people are concerned on both sides of the aisle. Every American should be concerned. At least we're kind of waking up and smelling the burnt toast. I would love to see a single payer system. It makes so much more sense. And you can't argue with numbers. The countries that have single payers pay a lot less for healthcare than we do, and they live longer. Japan has a single payer system, and they have no infant mortality. They live longer than anybody else in the world. They spend about 8% of the gross domestic, 9% of the gross domestic product on healthcare, and they are prodigious users of healthcare services. They visit the doctor more than anyone else in the world, and yet they still have what some people think is the best system in the world. But other countries that have thought about this realize you have to have everybody included to give health care in a reasonable fashion to anybody. That's what insurance is. And Ryan wants us to go back to just a proprietary system where no insurance, everybody is on their own. I mean, it seems like what he's trying to do. It's the Stone Age. I mean, it's scary. But I'll just say this one last thing. I asked this question to my students first day of class, my medical ethics class. And I said, is healthcare a right or a business? And most of them, some of the business majors have to think about it, of course, but most of them say it's a right. Most Americans say that too. But the problem with Americans is, they don't trust anybody in government to help provide it. So we think it's a right, but we can't ever agree on having government provided because we don't trust government. Other countries don't seem to have that problem.
I think it's even a larger question than just healthcare. I mean, a lot of the conversation around the ACA and around the AHCA are talking about the healthcare system, the delivery of healthcare. And I think it's a much bigger question about how we as Americans look at health in general. And I think this gets to some of the things that we've talked about with death and dying and, you know, just what we consider healthy life and what we consider when enough is enough and too much care. And, you know, we haven't had those conversations either, but I think those conversations are part and parcel with the American health system because that's cost and access and all of those. You know, if you grow up with a healthy lifestyle, you're much less likely to have chronic disease. You know, you're much less likely to develop diabetes and require, you know, daily insulin and all of those factors that are associated with the high costs. So I think there's a cultural aspect that goes beyond even just thinking about the right, the business, the privilege aspect, but it's just the way we as Americans think about our lives and what we consider to be health. You know, what is it?
I will be more optimistic, just for the sake of trying it out. I think that we're probably as close as we've been in a long time to moving that direction.
Yeah.
And I think in part because for all of the fear and anxiety that I have about this particular bill that's being discussed in the House right now, they have moved the line down. So what I mean by that is I think before it was very sick, very old people who might have the greatest, like who might be hurt the most, for example, right? Because we spend more dollars on care at the end of life than we do from birth all the way through to that moment, right? You've moved the bar down now. If we're talking about 50-year-olds have the potential to be greatly impacted, right?
I know.
You know, people who are the gap now is different. It has changed, right? Because before the gap, like with Affordable Care Act, was some like people in this like weird hole of like they weren't poor enough, but they weren't wealthy enough, so they couldn't get Affordable Care Act. Now we're moving the bar. The Republican bill moves the bar down so that now if you're like 50 to 64 years old, you are now become part of a riskier group. And so I think the potential, if somebody with the political will and the ability to rally the people who are clearly not paid protesters out resisting, I mean, I think if somebody were to come along and say, okay, look, we have X number of millions of people, millions. It's not like I don't think it's a small number of people who would be willing to stand behind that, right? And so I think the potential is there if we really start rallying around that idea, because I think we're starting to see the ways in which it's going to start hurting sooner, and a lot more people that are closer, even to younger. You know, our students, for example, our undergraduate students have parents that are getting very close to that age, right? So I think the potential is there, but it's going to take the right people in the right place to drive that conversation.
And on that note, I'd just like to thank you all for coming and speaking with us today. Thank you.
Thank you. Thanks.